We have gone too far with the modernization of the treatment. And number two, thinking that the super specialist is the best person to treat diabetes. These have been two big pitfalls in last 30-40 years. So what we need to do is, and what I'm going to do today is, come back to the grassroots.
Very good.
Come to the drawing board again. There is no role of कि साहब नई दवाई कौन सी आई है, कौन सा डॉक्टर नई दवाई लिख रहा है, एक ने नहीं लिखी तो दूसरा लिख देगा. The data is still that we have not been able to achieve the targets in our type 2 diabetics despite the best basket of medications. India has so many million, trillion diabetics. We have very few doctors. And specialists, if you call an endocrinologist as a specialist who should treat diabetes, I think all the diabetes people will remain untreated. We have 56,000 MBBS seats. Hardly 12,000 people can do a MD every year, and hardly 100 seats for the DM endocrinology. We are churning out primary care physicians, and I think this is the right approach, because most of the conditions are still being treated and should be treated by primary care physicians. And that is why today's talk will not touch upon anything new drugs, new technology, because we have to go back to basics, and only then we can control the disease, the disability, and the complications. Here is a person who's in the prime of his youth, 50. He weighs a lot, 87 kgs for his height. He's diabetic for 8 to 9 years. You can see his fasting sugars are so high, postprandials are even higher. Blood pressure is okay. HbA1c, as you see, is way beyond the target. And this is the common man. This is the usual person who comes to your clinic, to my clinic, being treated for 8 to 9 years. He is on the best medication, I can tell you. He is on the latest and the oldest, all combination in the maximum doses whatsoever. Why is he not getting controlled? See, our targets are that this guy should lose weight and come to about 70 to 74 kgs in about 6 to 9 months. So this is a task cut out for us for this patient. And we have to bring HbA1c to about 7% in next 3 months. And the LDL to be 100 or below, and triglyceride 150 or below. Now, how do we do that? We find out why this is happening to him. It's happening to him because there is a lack of exercise. He does not have time to do exercise. That is the first thing he's going to tell you. Second thing he's going to tell you, he's too tired after the day's work. He may also tell you, nothing happens with exercise, I've tried it. Well, he still needs to do it. And who's going to tell him? Us. And this guy also has more than triple of advised cooking fat per day. Now, unless I ask this patient or his wife, what is the amount of cooking oil being used in your kitchen? How do I know, and how do they know that they are supposed to have half liter cooking oil per person per month? If if he goes without telling me, or if I go without asking him, he's going to continue to do the same. And we are going to control the LDL with the statins? No. Go back to basics. So the corrections for all these three things were advised. So we advise him, please stick to 14 to 1600 calories, and we elaborate, we explain. Increase the fiber content, not more than 50% carb, 20% fat and 30% protein. This is the basic for a person who does not have a renal failure, does not have any other problem. And 45 to 60 minutes of brisk walk at least 5 days a week. What happens? Screen closed. What happens in 3 to 4 months? He can control his weight. His A1C comes to 7.1. LDL, BP, everything in the normal range. Mind it, here we have not added a drug or increased the dose of any existing drug. Believe me, this is truth. Let's go to the other patient. This madam is 59 years. She's diabetic for 30 years. She is supposed to be totally in control of her diabetes because she has learned everything in 30 years. But if she has not, then we got to do it. For her targets are again better control of sugar, blood pressure close to 120/80, weight reduction of 10%. As you know, at any given point in time for an overweight diabetic, the first target is to reduce the existing weight by 10%. By reducing the weight by 10% of the existing weight, you reduce the risk of heart attacks by 30%. First of all, I am supposed to know that. And second is, I am supposed to make a deal with the patient. Just 10%. You are 100 kgs, come to 90 kgs. You are 90 kgs, come to 88 kgs. So we do that, and what we get, of course, we found another observation in this patient. She was on insulin. We found that her fasting sugars are all the time high. And increasing the insulin dose made her fasting sugars even higher. Why I am taking up this kind of a situation? This is pretty common. You and me, we are all giving patients insulin. She's diabetic for 30 years. Her beta cells are, next to nothing. So she needs insulin along with the oral drugs. And she's on insulin. She's on a pretty good dose of insulin, not controlled. Her fasting is still high. What is happening is that she is going into some kind of one of these two phenomena. There could be either a dawn phenomena. Dawn phenomena is when normally there is a lot of hormones are released and the early morning blood sugar is high. When we check the fasting sugar, we check when we wake up. In this lady, the waking up sugar was always high. So we tried checking blood sugar at 2-3 a.m. We found it was going low. So it was the other phenomena called Somogy phenomena. Two phenomena, out of the two phenomena, the Somogy phenomena is when we have excessive amount of exogenous insulin being given at night. So we think by adding more insulin, we'll control the fasting sugar. We keep on adding. Exactly the reverse is happening. Plus, we are putting this lady at risk of a severe, undetected, pathological hypoglycemia 2 a.m., 3 a.m., 4 a.m. We found this and we corrected. Of course, we did all the diet and other things, and we emphasized this lady for this. And we made a deal again. That look, lady, we'll reduce your insulin and you will get better. And we did. We reduced our insulin, night insulin, by 25%. And over next 2 weeks, the fasting sugars came down to good levels, and post breakfast followed suit. There was few things to be changed, altered in this lady. She was on ramipril, amlodipine. Few changes were made. These are ones which we do make, and we are quite efficient in doing it. We just learned that if the hypertension is not controlled, you add one agent to remove the other agent. So the blood pressure also came under control. After 3 months, mind it, we have not added any anti-diabetic agent. We have reduced the dose of insulin, and what we get is the average fasting blood sugar has come down to 110 to 130, and postprandial is less than 180, and HbA1c 7.8. Not a bad target. In 3 months, if we can go 1 or 1.5 percentage point down HbA1c, we are looking at 7% in the next 3 months. So what we have done by doing the basics with this patient is that we have made her believe in herself, believe in the importance of lifestyle modifications, diet, exercise, and that's going to go a long way. Now, we have discussed these two patients. Now, there are always some bottom lines. What we should not do. The most important thing for a surgeon is when not to operate. Most important thing for an interventionist is when not to intervene. And most important for us is avoidable sins while prescribing medicine. These are, gentlemen and ladies, some avoidable sins when we treat diabetes. Metformin, excellent drug. Almost every patient should receive metformin, irrespective of whether he or she likes it or not. But in advanced renal failure, advanced liver failure, advanced CHF, and ketoacidosis, the metformin has to be withdrawn, not to be prescribed. Otherwise, we are asking for trouble. Similarly, pioglitazone. Pioglitazone is not a banned drug, but as you know, today we are using less and less. The most important thing is that when there is a heart is weaker, if the ejection fraction is 40 or less, it's a sin to prescribe pioglitazone. And if the patient who's anemic for any reason, these are two absolute areas where pioglitazone not to be prescribed. If it is being taken, please stop it. And prescribing drugs like glimepiride, which has 85% renal clearance in renal failure. There are a lot of medicines like repaglinide, even the sustained release gliclazide, and newer gliptins, which are absolutely safe. They have hardly any renal clearance. So to do all this, I think we need to do the renal function of our patients. Those who are doing well at least once a year, and those who have a bit of a problem, twice a year kidney function. Now, these are the areas by which we will make and try that a particular patient who is uncontrolled gets controlled. How? We come to the diet and spend at least 5 minutes with the diet with the patient. We tell the importance about glycemic index and the correction, how we use low glycemic index and medium glycemic index food, split the calories, discuss about the carbs in this, and what we get is, in uncontrolled blood sugar patient, 50% achieved. Now, when we come to the next thing and make sure that the diet is, exercise is properly explained, encouraged and done, in uncontrolled sugar patient who has come to you, who's on insulin, medicines, everything, if you have done these two, you have reached at 75% of your task. Sugars are getting controlled. And then we must look for some infections. These are very, very important areas. A diabetic has infections because of uncontrolled sugar, and the uncontrolled sugar is getting worse because of this infection. So these poor guys are in a vicious cycle. Most common are urinary tract infection, chronic colitis, lower respiratory tract infections, especially tuberculosis. Once you handle this, you reach about 80%. You have done your job 80%. And then stress. Of course, all my patients says, no, I'm doing everything fine. Because I am under stress from my daughter-in-law, my sugar is not coming under control. Well, don't just ignore this. Stress is a factor. Stress does cause the anti-insulin hormones to come into the blood and raise the sugars. Don't ignore. Try to have some counseling regarding this. If you can't do it, someone else should do it. And then you have reached about 85% of your job. जो आप फीस ले रहे हैं उसका 85% जस्टिफाई हो गया. And then try and discuss the targets. What are the targets? If we don't achieve it, what are the complications we are looking at it? And then individualization of targets. It's a guy who is 40, who just detected diabetic. Our target is to bring HbA1c to as close to non-diabetic levels as possible, 5.7. We should look for 5.7 and nothing more. Person who's 60 plus, has had AMI, keeps getting mild anginas, has a bit of LV dysfunction or a bit of rise of creatinine. Better be realistic, HbA1c not below 7, around 7. Then there is a person who has seen the world more than you guys and me, who's 75, 80, is still alive with the diabetes. He has seen all the cardiologists and cardiac surgeons, done everything, and is still alive. Give him a leverage. He can enjoy HbA1c of 7.5 or a little more. Mind it, it's not a courtesy. It is important that this senior citizen should not be asked or tried to bring down the HbA1c to 6. He's going to have silent hypoglycemias. He is going to get arrhythmias. He is going to get precipitation of anginas, and he may pop off with hypoglycemia. If not, his dementia will progress faster. If you keep getting him small doses of hypoglycemia every night. So, individualization of targets according to age, kidney functions, cardiac status, etc. So whatever 85% you justified, you have consolidated that. And then comes Very small role of medication modification, because we have already done that. We have gone to the moon, going to the Mars, everything. We don't have safe drinking water. So what we are trying to do is clear our basics. Of course, if there is a medication ऊपर नीचे करना है, that is as important. And when we do that, it's all done. So in 10 minutes, you've done everything. So we the physicians are not supposed to run out of ideas. That's what we are paid for. That's what we have been taught. Go and handle the patients, improve their lives. At any stage, we are not supposed to run out of ideas. Never. Thank you.